Hello everyone, let's see Hip Osteoarthritis Physical Therapy Clinical Practice Guidelines revision of 2025. So first we see the summary of osteoarthritis in hip. We see the key clinical examination findings for the patients with hip pain and mobility related to hip OA. So what are the things we can see? So the person is over 50 years of age, moderate anterior or lateral hip pain during weight bearing activities, morning stiffness less than 1 hour after waking, hip internal rotation ROM less than 24 degree, internal rotation and hip flexion 15 degree less than the non-painful side, increased hip pain associated with passive hip internal rotation, absence of history activity limitation and impairment inconsistent with hip OA. Factors in 2027 summary is age, history of hip developmental disorders or previous hip joint injury, reduced hip ROM, especially hip internal rotation, presence of osteophytes, lower socioeconomic status, high bone mass and high BMI or risk factors for developing hip OA. Regarding imaging, plain film radiography is one of the most often used method to diagnosing and assessing the progression of hip OA. And also these radiographs are used to look the amount of joint space narrowing and presence of osteophytes and subchondral sclerosis or cyst. Do this assessment for the hip OA patient. So first one is activity limitation. As a self-report measure, you use WOMAC, WOMAC Physical Function Subscale, Hip Disability and Osteoarthritis Outcome Score, Patient Reported Outcome Measurement Information System. Like the next one is physical for performance measures. Activity limitation, we need to assess. 6-minute walk test and 30 seconds chair stand test, tuck test and timed stair performance. Then third thing we need to assess is the physical impairment measure. So now we go into hip ROM and muscle strength for internal rotation, external rotation, flexion, extension, abduction and adduction of hip. All this thing for hip. For pain, assessing pain, we use NPRS, numeric pain rating scale. For assessing the joint irritability, use the Faber test. So now we go to the management part regarding the physical therapy management. The first thing is manual therapy. So manual therapy also includes soft tissue mobilization, massage, dry cupping, instrument assisted techniques also it can include. And also myofascial trigger point therapy, muscle energy or strain or counter strain techniques also you can include that. Usually for mild to moderate hip OA, clinician should use the manual therapy for patients. For also the patient having joint mobility impairment, flexibility impairment or with pain, you can use that. These studies in the recommendations also have gaps in knowledge that so most of the manual therapy studies are having short-term benefits only. We need to assess the longer-term benefits of manual therapy treatment. The second management is flexibility, strengthening and endurance exercises. But currently we need more research that use of both land and aquatic exercise program for various dosage, including different treatment frequencies per week. For subtypes of hip OA, we need to assess in this kind of studies. The current recommendation for exercise is you can use an individualized exercise program including aquatic therapy as well and also other exercise therapy to improve motion, strength, function and pain. So dosage include 1 to 5 times per week, each lasting 30 to 120 minutes over a duration of 5 to 16 weeks. Keep remember this. Okay, in this clinical practice guidelines they also included dry needling therapy. You can also use that, but you need to must know that you can use with other physical therapy intervention used as a combination only. Don't use as a standalone treatment. But still we need to know the long-term effects of dry needling on muscle extendability, pain, ROM, function and muscle force production. Next most important thing is patient education combined with the exercise and manual therapy. So you should educate about teaching the activity modification and supporting weight reduction when the patient is overweight and methods of unloading the arthritic joints. And also another recommendation is weight loss. Addition to providing exercise intervention, we as a clinician, we must collaborate with the physician, nutritionist or dietitian to support weight reduction in individuals with hip OA if the person who are overweight or obese. So also in research aspect, we see the patient education related research in hip OA and the use of weight loss for patients with hip OA is very limited since the 2017 revision. So we need to keep in mind that. Also include functional gait and balance training. So regarding modalities, we can use ultrasound. In 2017 recommendation, it was we can use ultrasound 1 megahertz 1 W per centimeter squared for 5 minutes each to anterior and lateral and posterior hip for total of 10 treatment over 2 weeks period we can use that. In addition to exercise and hot packs in short-term management of pain and activity limitation in patients with hip OA. Next is bracing. Clinician, we should not use bracing as a first line of treatment. A brace can be used only after exercise or manual therapies are unsuccessful, improving the patient participation in activities that require turning or pivoting. With patients with mild to moderate hip OA, especially bilateral hip OA. And also regarding alternative or complementary treatment, as per 2017 summary, there is insufficient evidence to support the use of supplements such as glucosamine, chondroitin, hyaluronic acid, injectable or similar substance for the treatment of hip OA. First, in 2025, the authors have no new comments. Next one is anti-inflammatory agents, NSAIDs, COX-2 inhibitors and steroid injections are effective treatments for relief of symptoms in patients with hip OA. Some evidence suggests that NSAIDs may increase the progression of hip OA by decreasing glucosaminoglycan synthesis. However, data are not conclusive. So as a clinician, we must aware the incidence of serious gastrointestinal side effects associated with use of oral NSAIDs. So since the anti-inflammatory agents and the complementary treatment as cannot done by a physical therapist, for a knowledge purpose we need to know this. Evidence-based physiotherapy related contents.